I've been better, I've been worse. I've chased after pretty girls. I've seen a couple places that I never thought I'd see. I've walked into harder times, I've walked out the other side. It seems like you end up getting what you need. Yeah, looking down from 30,000 feet, life's been good to me.
And I hope that life has been good to you all. Welcome to Stretcher Fetchers, another week, another podcast. My name is Allison, and let's throw it in there. None of my opinions or my statements are affiliated with my department. This week, we're going to be talking about trauma in the nursing homes, and this is a topic that is intended to educate you guys about the signs and symptoms of patient neglect and safety measures that can be taken in these environments. These can also include rehabilitation complications that can happen in subacute locations and home safety evaluations. Let's not waste any time and let's get going. The aging population is a special topic because not only do these people have assigned proxies that make care decisions for them, but they also have changing nursing staff members who depend on documentation and good shift change reports to continue quality care. The geriatric patient is a patient that is 55 years and older. It's important to note that age does not define a geriatric patient. It is care that is required for the patient that needs a specialized doctor. Patients can be in their mid 70s and still be treated by a primary care provider with no complications. Some medication conflict examples that could be treated by a geriatric provider include something like a diuretic that is needed for a patient with chronic kidney disease, or certain antibiotics such as Bactrim with long-term anticoagulants. This can raise their risk of bleeding. These patients can also depend on assistive devices for mobility of activities of daily living, and one of those activities could possibly even be hearing. When you're dealing with a patient with hearing loss, there's some important things to keep in mind. The communication can be a little bit hard but not impossible. Hearing loss can include speaking clearly and loudly, but not yelling, asking the patient if they have a better hearing side, and avoid shouting to address the patient before speaking. You should try and face the patient that you're speaking to and ask the patient to repeat instructions to ensure understanding. You also possibly run the risk of someone that's hearing impaired and also has dementia or Alzheimer's. Give the patient time to process questions and answer and acknowledge that they are being asked certain questions. You should give them simple choices to answer for possibilities, and this is what I call a modified closed question. These patients can answer yes or no, but you should try and keep with one question at a time. Wait until you get an answer and then ask them another one. When patients are no longer in a cognitive state where they can make their own educated choices, geriatric patients can depend on someone to speak for them and make their medical decisions. When a patient is no longer showing the capacity to make their own decisions, they can go through the process of appointing a durable power of attorney or a designated decision maker that is signed off by two providers. This would allow someone to make decisions that is in their best interest. They can at this time choose what type of advanced directive they would like, what kind of measures they would want taken, and typically the patient chooses someone that would keep their considerations in mind. They would make decisions that would be consistent with what they consider a quality of life. So the original surrogate is a person that is assigned to make these decisions, but you can also have a default surrogate, which is an alternate if the DPOA is not reachable. For those that maybe don't have kids or have estranged family members, this patient can be assigned a court appointed guardian, which is an assigned DPOA, and this is not necessarily chosen by the patient, but it can be a worker of the state or a voluntary friend that has stepped up to make these decisions. Court appointed guardians can often lead to the patient staying in the hospital until a DPOA is chosen for them, and the care timeline often continues after this decision has been made. At this time, the patient defaults to healthcare provider judgment, which is urgent decisions affecting the patient's life in the emergency room in an outside of healthcare facility environment. Educated choices are made based on the expected outcome of the patient. This includes starting CPR and also doing any life sustaining treatment. When the patients finally get a court appointed guardian, this is someone that checks up on them. They speak in the best interest of quality of life care decisions. And there's different levels of court appointed guardians. Sometimes they're very involved, but sometimes they're just collecting a paycheck. And that might not always be the case, but they definitely don't know enough about the patient and they are just making choices based on reason. Seeing as a patient in the nursing home may not be of sound mind all the time to make their own decisions, it's important to know your options when patients have medical emergencies. The best choice is often to contact their emergency contact that is listed in their intake paperwork. When medical emergencies occur, the emergency contact may be close enough to make it on scene before your ALS arrives to transport the patient. So a report can be done face to face and decisions can be made on scene. If your DPOA or emergency contact is not able to make on scene, you can contact them over the phone and voice what hospital they would want the patient transported to if they do want them transported and if they will meet them there or not. It may be helpful to remind the contact to keep their phone on them in case the ambulance crew needs to get a hold of them on the way, such as a location change or a condition change for the patient. You can always default to the patient's advance directive if that is available, and place a phone call to the DPOA to confirm that this is still the correct choice that will be made considering treatments. Lastly, med control is the best route of care if the guardian is not able to answer and the patient needs vital treatment. Med control is not necessarily someone that only needs to be contacted when there's a true emergency or when you're giving medications that maybe conflict with patients' conditions. Med control is a resource that should be used whenever there's any type of confusion or any type of loose ends that are on scene. It is really helpful for any EMT or basic to have their emergency online director or their med control number saved in their phone for when they are providing care on scene. When it comes to elderly living facilities, there are a lot of different levels. The first level is called independent living, and there's no care or medical services that are provided to these patients. They have the capacity to function in their own way, and they may benefit from some living spaces that are smaller than a house, or they prefer a community style apartment to stay social and have a sense of reassurance knowing that others are nearby in case something happens. These populations have the option to get a ride assistance or even drive themselves to run errands. When older populations are in central locations, this is often referred to as a retirement community. The next level down is an assisted living. This does include any type of nursing care. This can be referred to as a long term care, and these locations give medications, they answer call lights in rooms, and they provide meals that are cooked for the patients in a cafeteria style. Periodically, patients are taken out of their room for socialization and planned activities to maintain overall mood and break up the days, give the residents something that they can look forward to, and motivation to keep track of the calendar. Subacute rehabs are sometimes tied up with assisted living, and there's different wings, but these are post op patients that may find themselves staying in these types of locations for a period of time following an illness or injury. It can be anywhere from 6 to 12 weeks. It could possibly be longer, but it is fully staffed with nurses and doctors who provide physical therapy and occupational therapy to improve activities of daily living enough to send them to a lower level of care. Participation is required for this patient to maintain this location of living, and they may be at risk of being discharged if they refuse treatments. Insurance often covers these locations. There is also an adult foster care. Adult foster care consists of adults that are 18 years and older with special needs and locations that are often limited to less than 20 adults. They will receive personalized and intimate care, and guidelines for these facilities are often looser than assisted living, seeing that the individual homeowner can make their own rules as long as they are following mandatory state regulations. These members are not always geriatric, but they are highly dependent on caregivers for their activities of daily living or ADLs, and they may be an alternative to when patients do not meet requirements for staying in a long term care facility. Lastly, you have home care. Patients are able to stay in their own homes and they do not require 24-hour care. They are granted a prescription when medical necessity has occurred, and they get unskilled services that can be provided by family, friends, home health aides, or certified caregivers. This is a socialization for the patient, and it's possibly a type of environment where the patient may experience financial abuse from their caregivers that they are dependent on, and they have them run errands like going to the bank or managing money. On the topic of nursing homes, one of the first signs of neglect that a patient could possibly experience is a poor nurse to patient ratio. Typically, for a 24-hour care that has patients with very intense and complex needs, it's not recommended that there's more than two patients that are being cared for by one nurse. If a patient is a little bit more independent or has fewer treatments that they need throughout the day, that ratio can increase to four patients to one nurse. Once you hit the type of elderly living facility where these patients are basically just getting their medications and getting rounded on, you can stretch that from one nurse to eight patients during day shift and up to one nurse to 18 patients on night shift if there's low need. If there's high need, that ratio does drop down to 12. The risk that you run when there's less nurses that are ratioed to patients is that each patient and resident is getting less face to face care due to the patient to medical staff ratios being extremely inappropriate. This can include longer wait times for bathrooming, so the patients may attempt mobility on their own. Patients that are attempting to be mobile when they are typically a 1 to 2 person assist can increase the risk of falling and the likelihood that a patient has repeated accidents in their undergarments, and this can lead to skin problems and UTIs. These patients will be left feeling dehumanized and angry at their situation, and they may often lose trust in their quality of care. Additionally, patients with cognitive decline or decreasing mental capacities can wander off with no one to keep an eye on them. These are often the 911 calls that are documented almost every day of a geriatric person that has wandered off from their caregiver, or an emergency medical and security resource has to spend hours or days looking for these patients who are exposed to traffic and weather conditions that they are not normally interacting with, and it can leave them with medical complications and exposure injuries if they're left outside for too long. All of these locations can feel the pressure of having patients that constantly depend on them, so it's important to educate yourself on signs of abuse. This abuse can be intentional, such as hitting or kicking senior citizens, but it also can be negligent failure to meet the needs of these patients that the caregivers are responsible for. The first one to note is signs of abandonment. When someone who has custody of another person deserts them without regard for their well being, this can be a wide spectrum from family. EMTs and paramedics are even susceptible to this. Common types of neglect can be EMS handing patients care to a lower license, nursing staff not looking into questions that the patient asked them to find answers for, or residential locations not having enough caregivers to meet the nurse to patient ratios that are recommended by the state. When a facility fails to train their staff appropriately, this is contributing to patient neglect. So often you'll see mobility assists like a Hoyer lift, and this requires a lot of staff that are involved with moving this patient. There's a sling that goes underneath the patient, and you also have to watch for any obstructions that the patient may get stuck on if they're not lifted high enough above their bed. So, if you're not familiar with the equipment and the strap is not secure or in the wrong location, the patient can experience a fall from height, and staff can additionally get injured by the equipment or by the patient. The staff can also be susceptible to making medication errors. This can sometimes not even be at the fault of the nursing staff, but if they don't have enough staff to make sure that the as needed medications are administered appropriately, a patient can get too many painkillers or they can get not enough of their scheduled medications because documentation falls behind. And this leads to an increased overdose likelihood mixing up a patient's medications, possibly time wise, or with another patient, or administration that is in the wrong method. There is often typically just one or two skilled licensed nurses or nurses that went through actual school, and then you'll get a lot of your nursing home aides that are certified nurses or nurse techs. So, when they're not properly trained on the aging population, they can miss signs of mortality that the patient is declining to the point that they are going to go into cardiac arrest or that they're going to be deceased soon, and they can often miss these signs of decline until it's too late. Medical neglect can also be occurring in these healthcare facilities when nursing homes or providers fail to properly treat or prevent health problems. This can result in bed sores and infections. Other examples can be not rotating patients, changing saturated dressing, or even having them miss their therapies due to transportation issues or not having the ability to send a nurse with them, and this can ultimately result in a mobility decrease. The patient can be declined basic needs when facilities fail to provide these residents with enough food or water or a clean, safe environment. This includes personal hygiene neglect, like dental care, laundry. If you guys see piles of laundry building up, if the trash is overflowing, or if they haven't been bathed because they're typically a difficult patient to try and get showered, these patients get completely preventable infections and wounds from lack of hygiene. They also can get declined aids such as walkers, being close enough to their bed, having their hearing aids charged, or even getting their dentures so that they can have normal conversations and eat their meals. The patient is ultimately kind of subject to neglecting themselves, and this may not always be the care facility's fault, but this type of neglect is when adults lose the capacity to care for themselves, but they do not seek assistance. This can include EMS not reporting hazardous living conditions if the patient lives in a residential location, but also if the nursing staff is not spending enough time with the patients and they are lowering their speculations to push for the patient to look into guardians. These patients can seem completely cognitively aware, but often I find that patients with early onset dementia can hide it very well, and they can convince everybody that they're fine until you really start having a conversation with them and realize that some of their statements don't line up or some of them don't make sense with current events. The patient can be subject to social neglect, and social neglect can include leaving patients alone in their rooms for a very long time and not letting them interact with family, friends, or other residents. This was a really big thing that happened during COVID, where you could only have family members that could visit by windows, and it was really easy to get away with just leaving a patient in their room for a really long time because everybody was worried about getting sick. But when they're left in their rooms for social events and they don't address them when they come into the room, this demeans the patient during their care and often dismisses their reactions to situations. This can definitely be a big contributing factor to emotional neglect in the nursing home. The number one thing that I'm typically looking for when I go into a patient in a nursing home or a assisted living facility that has an altered mental status is I always check their heels. A lot of patients that are diabetic or have low mobility can have their legs and heels that are resting on the bed, and a pressure ulcer starts developing. This presents as a bruised or red looking area of skin on areas that are in contact that the patient has, where the skin and the bedding are constantly touching, or chairs. So, heels, butts, backs, these later develop into macerated skin or open wounds. Macerated skin is like when you're sitting in a bathtub and your skin kind of shrivels up. So, if someone is sweating or if someone is constantly wet and not getting enough powder to keep their skin dry, this is really susceptible for these patients to get pressure ulcers. You can also find that the patient may not be having their heels elevated if they're a postoperative patient, and this patients that get like a hip hemiarthroplasty or any type of ankle surgery, if they have something that prevents them from lifting their leg on a regular basis, these bruises and wounds can go all the way down to the bone if they're not found in a timely fashion. Patients that have dementia or may have some cognitive disorders, maybe they're suffering from depression, they can have dehydration and significant weight loss. If you've seen on their after visit summary, or if they've been weighed and they're constantly going down in weight, or the nurses are not making sure that they're raising any red flags that this patient is not eating their food, these patients can kind of waste away. Ultimately, if you get a combination between pressure ulcers and postoperative patients, patients with UTIs that have infections that have gone untreated, they can become septic. And this is not always a sign of neglect, but it often kind of goes hand in hand, where it's an extremely developed local infection that has turned into a system wide problem. Symptoms for sepsis have been evident, and the nursing staff may not necessarily catch them, but it indicates that the patient needs antibiotic care, and this may be overlooked for multiple different reasons, like the nurse to staffing ratio, or the fact that they may not be verbalizing that they have these ulcers or they are not feeling well. They might have dementia. And so when they have an altered mental status, it may not raise red flags soon enough. Their behavior could be a cause of cognitive decline or untreated anxiety. And finally, the most evident would be an unhygienic environment with those dirty sheets building up. If the patient is sitting in urine for a really long time and they smell of urine, bruises, if the patient is kind of low mobility and stressed nurses or stressed family members are kind of at their wits' end, they can have bruises present on their wrists and at their shoulders from being pushed into the bed or from being pulled up rather roughly. And elderly people have what I like to refer to as tissue paper skin. So they are susceptible to those frequent bruises, but also they get those skin tears. And important features to note are age, layers of different bruising colors, and the size with the markings along the location. As far as skin tears go and injuries additionally to these falls, if a patient is found on their back end, but they have a wrist and elbow injury, it could possibly be because they fell forward out of their wheelchair. So, kind of knowing your mechanisms of how injuries happen is important. A patient that has a shoulder injury typically fell from a height or they were pushed down with force. And patients can have inversion injuries to their ankles, which means that their ankles were possibly rolled over with a wheelchair or improperly transferred into their bed, where their feet were maybe left behind and stepped on, causing a twisted ankle or even foot injuries from having their feet rolled over with equipment. Lastly, as far as injuries go, we do always run the risk of burns. When I was working in the burn unit at the hospital, we would be able to tell if a patient had a injury from getting into the bath or if they were placed into the bath. If the patient has burns that are on the bottoms of their hands and on the bottoms of their feet, they typically stepped into it and the bath water was maybe too warm or they fell forward. But if the patient has burns that are on their butt or on their back, the patient could have been placed in water that was maybe not monitored to be the correct temperature before the patient was placed in it, which leads to my last talking point of nursing home neglect, which is negligent hiring. Negligent hiring is deferring to check for criminal records that include abuse history, and this increases the resident's likelihood of being abused to any extent. The nursing homes can find themselves deferring drug screening, and this can prevent quality assurance that the patients are getting care from somebody that's not using substances on the job or possibly drinking, and this will affect their work, increasing the likelihood of injuries and mishaps in the nursing home. Lastly, if they are not checking that their staffing is staying up to date on licenses, this can include nursing certifications or caregiving certifications, CPR licenses, and not doing updated trainings on how to use and facilitate equipment that's the residents depend on a regular basis to make their livelihood safer. These staff members may be requesting additional trainings, but because they're short staffed, they may not be able to do these facilitated trainings until after they get new members hired and onboarded, where they can fully afford to have some people step off the floor and get updated trainings. As an EMS worker, it can be really easy to think that you don't have any impact on these patients' cares. But if you're noticing that staff members are acting cold towards a patient, or if there's lengthy times from the actual incident occurring to when they called EMS, you can contact local law enforcement. And this is a great option for EMS workers that are on scene. You can also, in a home setting, request an APS or Adult Protective Services evaluation. This is for non urgent claims. If there is anything urgent that needs to be addressed, local law enforcement should always be your first option. Adult Protective Services will do follow up evaluations, home safety evaluations, and welfare checks. You can always pass along if you're doing a turnover report to an ALS agency that you think that they should be deferred to a social worker at the hospital. Medical social workers work at the doctor's offices and at the hospitals. They can provide resources for new homes and equipment. They can hire nursing home abuse lawyers, and they can assist with financial compensation. Originally, you can always start with making a complaint to the head nurse or physician. You can report any concerns and try to draw attention to staffing concerns. They will be familiar with these employees and they will bring attention to the staffing shortfalls. I think the best way to tie all of this together is to do a case study. So, you are dispatched at 10:38 a.m. to a Med 3 for an 89-year-old female. Nursing staff are reporting that the patient fell in her room and there is an unknown downtime. On arrival, you knock on the door for about 5 minutes before one of the nurses comes over to let you in. When the nurse is asked how to get to the patient, she claims she doesn't know who called and who the patient is, as she is just filling in from another wing. You find a nurse tech who is aware of the situation and she leads you to the patient. She apologizes for the wait, and she is on her second week of work while she is trying to care for 10 patients all at once while getting tied up with her patient getting back into bed. You'll notice here that you get the typical response from "This is not my normal patient," as we have nurses that are floating from floor to floor. You also have an inexperienced nurse tech who is working outside of her patient care ratio, and she is also only on her second week of work while she is overloaded with this patient load. On entry into the room, you find your patient still on the floor. Her walker is tipped over, and you can see that she has urinated. The patient is in a left lateral recumbent position. The nurse caring for her informs you that her caregiver has already been alerted and is on the way. The room has a strong smell of urine. You check the bed and you see that there are stained sheets. The nurse also says that she is on Lasix and has a UTI. The provider on site wrote her a script for antibiotics, but it is a holiday weekend and delivery from the pharmacy is delayed until Tuesday, which is 2 days away. With our original scene observation, we're noticing that the patient is in an unsafe situation and has possibly faced some hygienic contributions to her current disposition. Your findings for the patient include a blood pressure of 90/48, a pulse that is bounding of 126, she has normal respirations, normal oxygen of 94, and she is running a temperature of 101. For your physical assessment, the skin is flushed, diaphoretic, and red. There is an altered mental status of ANO times 2 with repetitive questions. She is reactive to touch and eye contact. Her injuries, as observed, are left hip pain with an obvious deformity of the left wrist. This is a closed injury. Since this patient is over the age of 65 with a distracting injury, for the spinal exam assessment, she automatically fails. So you apply a C-collar and you explain what's going on through the entire process. Remember, an educated patient is a compliant patient. You test the glucose. It's 159, and that's quite normal for the patient, but you place her on oxygen because the level was 94. You can start with a high flow non rebreather at 15 liters per minute, and do a pain assessment. We do a focused history and find that the patient is not able to recall the events leading to the fall. She also has some trouble remembering her medical history. As BLS providers, you will upgrade this patient to a Med 1 for a suspected UTI that has developed into sepsis. You can splint the left wrist, checking for pulse, motor, and sensory before and after, palpate her back to rule out any additional injuries, making sure to visualize and feel for them. Evaluate the left hip, which you find that you're checking the pelvis and comparing the legs. You find no new injuries with the left hip, but you still want to be gentle with the patient, so you keep her on the ground until ALS comes. You give a proper transfer of care report, including the information that you have found already, and also any information that would be relevant for their treatment. You assist them with transferring the patient onto a soft cot, and you place her on the stretcher. When the guardian arrives on scene, you speak with the guardian about your concerning findings involving her unhygienic environment and the fact that the nursing home was not able to recall the last time that she was seen well. You can also, if you feel necessary, request that ALS has medical social work talk to the patient and see if she can get a medical well being evaluation. If possible, the patient may need to move facilities or possibly get a more specific doctor's note that implies what type of care she needs to have more regularly. And that wraps up today's episode of Stretcher Fetchers podcast. If you guys like what you're hearing, make sure to like, subscribe, tell all your friends. But I feel like this was an episode that was definitely worth spending the extra time on because this is a population that's so dependent on us as medical providers to be advocates for them and make sure that they're not falling through the cracks. So go out there, be awesome, and keep doing good things. Thanks for listening and have an awesome day.